Dietary factors play an important role in the development of cholesterol gallstone disease. In general, a high-calorie, high-fat diet, characterized by high intakes of sugar, refined carbohydrates, saturated fats, cholesterol and trans fat, have been linked to an increased risk of gallstones and their complications. On the other hand, a diet rich in fibre, fruits and vegetables, plant proteins and monounsaturated and polyunsaturated fats is proven to be protective. A Mediterranean-style diet that emphasises fruits, vegetables, seafood, legumes and olive oil has been associated with reduced cholecystectomy risk in a study in French women. A high-fibre diet has been found to prevent gallstones in obese patients undergoing rapid weight loss. Some evidence suggests some of these dietary factors do not appear to impact the gallstone risk in pregnant women. Weight loss is an important strategy for reducing the risk of gallstones in overweight or obese individuals, yet the risk of gallstones increases when the weight is lost rapidly. In a study with more than 6,000 people participating in one of two weight loss programs, those on a 500 calorie per day diet for 3 months, followed by 9 months of weight maintenance, were 3 times more likely to need hospitalization for symptomatic gallstones than those who started with a 1200 to 1500 calorie per day diet. Although the rates of gallstone-related hospitalization were relatively low in both groups at 1.5% per year in those with a very low calorie diet and 0.4% per year in those on a low calorie diet, the results suggest the health benefits of weight loss can be best achieved through moderate calorie restriction. Generally, weight loss greater than 24% of the initial body weight at a rate greater than 1.5 kg per week has been identified as a risk factor for gallstones, but the risk might be mitigated by controlling the weight loss, reducing the length of the overnight fast, and keeping a small amount of fat, at least 7 grams per day in the diet, to improve the gallbladder motility. Coffee and tea appear to reduce the risk of gallstones, possibly by stimulating the gallbladder's activity. Moderate alcohol intake, which can stimulate the gallbladder emptying, has also been associated with a lower gallstone risk. Foods that contain polyunsaturated fats, like fish, and monounsaturated fats, like olive oil and nuts, appear to also be protective. In a study that followed over 80,000 women for 20 years, eating 5 or more servings of nuts per week was associated with a 25% lower risk of gallstones. Similarly, a study that followed 43,000 men for more than 10 years identified a 30% lower risk in those eating 5 or more servings of nuts per week, compared to those who rarely or never ate nuts. Garlic, onions, fenugreek, and components from other dietary spices like turmeric, cayenne and black pepper have each demonstrated the ability to prevent and to dissolve cholesterol gallstones in animal studies. Preclinical research suggests they reduce the cholesterol saturation in the bile, and they inhibit the first stage of cholesterol crystal formation. The gallbladder flush is a folk remedy for gallstones, and it's been popularized through natural health websites and books. The process recommended for the gallbladder flushing varies, but usually it entails a 12 to 14-hour fast, ending in the evening with the ingestion of a large volume of olive oil and lemon juice, typically anywhere from 2/3 to 2 cups of olive oil and 1/3 to half a cup of lemon juice. These are ingested over several hours. The expectation is the gallstones will be passed the following morning. In one case report, a number of firm green globules collected by an individual who performed a gallbladder flush were analysed and found to have none of the major components of gallstones, being cholesterol, bilirubin or calcium. Instead, they were composed mainly of fatty acids, presumably from the olive oil itself. Further examination suggested the globules might have been soaps created by the action of digestive enzymes on the olive oil and lemon juice combination. Nevertheless, there are several reports of cases where fewer gallstones were seen on an ultrasound afterwards when compared to before a gallbladder flush. To date, the various methods promoted to flush the gallstones have not been validated in controlled clinical trials, so they are not considered evidence-based. A sedentary lifestyle increases the risk of cholesterol gallstones, while being physically active decreases the risk. Physical activity might prevent the cholesterol gallstone formation by improving the gut motility and through positive effects on cholesterol metabolism. A systematic review and a meta-analysis that included 8 studies and a combined total of almost 7,000 participants concluded those with the highest physical activity level had a 25% lower risk of gallbladder disease, including gallstones, than those with the lowest physical activity level. The exercise might prevent silent gallstones, as well as gallstone complications. 2 to 3 hours of recreational physical activity each week reduces the risk of the gallstones by about 20%. Nutritional supplements hold much promise in preventing cholesterol gallstones and their complications. Individuals with high gallstone risk due to ethnicity, gender, age, family history, other health and medical factors, and those with known silent gallstones might want to consider these supplements to reduce the risk. Vitamin C is a water-soluble vitamin, and it's well known for neutralizing free radicals and for decreasing oxidative stress, a controlling factor in gallstone formation. The vitamin C is also needed for the conversion of cholesterol into bile acids. The ability of vitamin C to prevent gallstone formation is supported by several animal studies. The relationship between a vitamin C deficiency and gallstones has been recognized since 1970, and for decades a low intake has been implicated in raising cholesterol saturation in the bile and in increasing the likelihood of gallstone formation. In a controlled clinical trial, 16 gallstone patients were scheduled for cholecystectomy, and they were given 500 milligrams of supplemental vitamin C 4 times per day for 2 weeks before the surgery. Compared with similar patients who did not get the supplemental vitamin C, the study subjects had improved bile composition and a lengthening of the time required for cholesterol crystals to form. Another trial found a similar effect on 13 patients awaiting the cholecystectomy, who were given 1 gram of vitamin C twice per day. In an observational study on 2,129 subjects, the regular vitamin C users were 66% less likely to have gallstones than the non-vitamin C users, when assessed by abdominal ultrasound. The correlation between vitamin C levels and gallstone risk appears to be stronger in women than in men. Supplementing with fish oil or omega-3 polyunsaturated fats from fish that contain EPA and DHA might prevent gallstone formation by improving the bile composition and preventing the crystal formation. In a double-blind, placebo-controlled trial, 35 obese women with no history of gallstones or cholecystectomy were treated with a 1,200 calorie per day diet, along with either 11 grams per day of omega-3 fats from fish, urodeoxycholic acid, or a placebo for 6 weeks. While on the diet, the time needed for the cholesterol crystals to form decreased in the placebo and the UDA diet, but not in the omega-3 group, suggesting the fish oil might prevent the increase in gallstone risk seen with a low-calorie weight loss diet. S-Adenosylmethionine, or SAMe, exerts protective effects on the liver, and it improves bile flow in people with certain liver diseases. In a preliminary study that included 7 women with a history of biliary problems during pregnancy, taking 800 milligrams of oral SAMe daily for 2 weeks resulted in decreased cholesterol saturation in the bile. In a trial in 6 healthy women who'd experienced an increase in bile cholesterol saturation after starting oral contraceptives, the addition of 600 milligrams of the SAMe daily for 2 cycles of contraceptive use also reduced this effect. Curcumin is a carotenoid extracted from turmeric. Several animal studies suggest that curcumin can reduce the likelihood of gallstone formation by improving the cholesterol and lipid metabolism. The curcumin has also been shown to enhance gallbladder motility, reduce gallbladder inflammation, and normalize bile acid metabolism. In mice who were fed a high-fat, high-cholesterol diet, the curcumin protected against the development of gallstones, and its effect was enhanced with the addition of piperine, an alkaloid from black pepper. Curcumin might also be helpful in the recovery after cholecystectomy. In a randomized controlled trial, 50 patients undergoing a laparoscopic cholecystectomy were given either curcumin or placebo, along with a standard pain reliever to use as needed upon hospital discharge. The curcumin group had less post-operative pain and fatigue and used less pain relief medication than the placebo group. Curcumin has been shown in a few studies to promote gallbladder contraction. Therefore, people with a history of bile duct obstruction or who have active obstruction should avoid curcumin. Individuals with iron deficiency anemia have been found to have a higher risk of gallstones than those with normal iron levels. This relationship has also been verified in reverse. Gallstone patients have been found to be more likely to have low serum iron levels than healthy individuals. On the other hand, concentrations of iron in the blood and the bile have been reported to be significantly higher in people with pigment gallstones, which are often related to conditions marked by the increase in red blood cells being broken down. Iron deficiency anemia might alter the activities of several liver enzymes, leading to increased cholesterol saturation in the bile and increased cholesterol crystallization, and it also negatively impacts gallbladder motility. In addition, it's possible that gallstone disease contributes to iron malabsorption and poor iron status. Different forms of dietary iron might have varying impacts on gallstone formation. One study followed over 44,000 men for 16 years and had examined their iron consumption using a food questionnaire. The participants with the highest intake of heme iron, a well-absorbed protein-bound form of iron that's found in meat and seafood, had a 21% higher risk of symptomatic gallstones compared with those with the lowest intake, but there was no significant link between the intake of non-heme iron, which is found predominantly in plant-based foods, and symptomatic gallstones. The dietary heme iron has also been shown to increase the burden of oxidative stress in the body. Because of the role of excess iron in raising the oxidative stress and the risk of cardiovascular disease, it's important to have one's iron status assessed before taking an iron supplement. Those with iron deficiency should consider iron supplementation to reduce the risk of the gallstones. Vitamin E is a fat-soluble nutrient and it prevents and repairs oxidative damage to lipids in the body. The vitamin E is a term that collectively refers to 4 tocopherols, alpha, beta, gamma and delta, and 4 tocotrienols, alpha, beta, gamma and delta, with alpha tocopherol being the predominant form in our body. Observational studies have noted individuals with gallstones have lower blood levels of alpha tocopherol and alpha tocopherol to cholesterol ratios, and lower dietary intake of alpha tocopherol as compared to the unaffected individuals. Since oxidative stress is one of the factors believed to contribute to higher risk of gallstones, supplementing with this form of vitamin E might be beneficial for preventing gallstones. Epigallocatechin gallate, or EGCG, is a green tea flavonoid. The EGCG has demonstrated gallstone-preventing effects in a mouse model of gallstone disease, possibly through its anti-inflammatory activity. Findings from a population-based case-controlled study in China suggest drinking the tea might reduce the risk of gallstone disease and gallbladder cancer. However, other research has not found a clear connection between tea drinking and gallstones. Melatonin is a neurohormone produced in the pineal gland, and it may have a role in gallstone disease prevention or treatment due to its anti-inflammatory and free radical scavenging properties, as well as its beneficial effect on gallbladder muscle tone. In animal and lab research, melatonin has been shown to reverse age-related muscle dysfunction of the gallbladder and to improve inflammation and gallbladder function in acute cholecystitis. In a guinea pig model, the administration of melatonin prevented the formation of pigment gallstones. Silymarin is a flavonoid extracted from milk thistle, and it's been shown to counteract the negative impact of estrogen on bile flow in rats. The silymarin and silbin, its major active component, have been noted to reduce the bile cholesterol content in both rats and human subjects, suggesting it has a potential value in gallstone prevention and treatment. To book a consultation or to learn more about herbs, supplements and natural treatments, check out my website.